Hello, good evening, everyone. I hope you all had a great weekend. I welcome you to today's webinar on emergency management for traumatic dental injuries in pediatrics, part 1. My name is Dr. Sumaya Feki. I will be your moderator for this session. I am delighted to have you all here with us. This session is part of a broader effort to equip dental professionals with timely evidence-based strategies for managing dental trauma in children, an area of critical importance in pediatric care. It is my pleasure to introduce our speaker for today's webinar, Dr. Dina Rabea, an academic, a specialist pediatric dentist with extensive experience as an educator and a clinician. Dr. Dina completed her Bachelor of Dental Surgery with honors from Ain Shams University, Faculty of Dentistry, where she also completed her master's in pediatric dentistry. She later went on to complete her PhD in pediatric dentistry at Cairo University. Dr. Dina currently works as an assistant lecturer of pediatric dentistry and dental public health at the Egyptian Russian University and practices as a pediatric dental specialist with experience treating patients both in office settings and under general anesthesia. Her diverse clinical experience includes roles as an endodontist and restorative dentist, with her early clinical foundation including time as a general dentist in clinics of the Egyptian Ministry of Health. Dr. Dina presented her work at numerous international conferences, including the International Association of Pediatric Dentistry, Pediatric Dentistry Congress, and the Kenya Association of Pediatric Dentists. Her research has been published internationally in the Journal of Indian Society of Periodontics and Preventive Dentistry and the International Journal of Pediatric Dentistry. Dr. Dina also works as a peer reviewer for the International Journal of Clinical Pediatric Dentistry. Beyond academia and clinical practice, Dr. Dina is a global change ambassador with EcoChange, a participant in multiple UNITAR public health programs, and an eHealth Award nominee, and an entrepreneur and an advocate for innovation in healthcare. Dr. Dina brings extensive knowledge and experience in pediatric dentistry to today's session, and we are pleased to have her here with us. I would like to share a few quick announcements before we welcome Dr. Dina. This webinar is being recorded. It will run from 7 p.m. to 9 p.m. Nairobi time.
Okay, Dr. Sumaya.
Okay.
Any more announcements?
Yeah, we will reserve the last 30 minutes for questions and answers. Please use the chat box to post your questions. And for those interested in receiving a certificate of participation, please rename your Zoom display name to match your official name. And please remain muted during the presentation.
Okay, thank you so much for this beautiful introduction, Dr. Sumaya. And I'm really thankful for the EDPA for having me today. This is my first time amongst pediatric dentists from Ethiopia, and I'm really looking forward to meeting more of you in live and maybe on my email. I'll be leaving my contacts at the end of the webinar. So I proceed with part 1 of this webinar, emergency management for traumatic dental injuries in pediatrics. So at first, again, this is my first time with people from Ethiopia in the dental field, but I know a little about the culture of Ethiopia. I know about the Blue Nile, the obelisks, some of the traditional dance folklores, and the beautiful hair updos, me, myself being a curly head, the music, of course, the injera, and the coffee. And I'm again looking forward to knowing more about the culture of Ethiopia, which we here in Egypt have a lot of common together, being African countries, you know. So the intended learning outcomes in this webinar will be to how to deal clinically and also psychologically with traumatic dental injuries, especially in this part of the webinar in primary dentition. I'll be discussing the management techniques according to the latest updates of the American Academy of Pediatric Dentistry 2025. I'll be discussing how to minimize the psychological evidence of trauma, especially that we're dealing with a very young age category with maybe hysterical parents, a lot of blood, and also how to develop a structured approach to be using in all these kinds of trauma management. I'll be discussing a little about the dental photography and its impact on given a very good and followed up management. I'll also be talking about the latest guidelines for children exposure to radiation. And I'll be hinting on child abuse and discussing the management of both fractures and luxations injuries in details. So let's proceed with minimizing the incidence of trauma. So again, you are dealing with a very young age category. Maybe the peak is at 2 years, 3 years of age. And then another peak is at about 5 to 6 years of age. This is the age where the children start to explore their universe. They fall a lot, they move a lot. They are maybe hyperactive, reaching out everywhere. So we expect at least one time of a trauma, maybe a dental trauma. So it's very normal to happen at this age category. But what's not normal is getting a blooded child at your dental office and having this child as their first dental visit. At this very young age category, it might be their first dental visit in a dental office, and having all of this blood trauma, again, the hysteria of the parents, and it's very understandable at this point. Sometimes you lose your nerve as an operator when this happens. So the first advice for myself and for you is always to try to keep calm, or at least show you are calm, even if you're not. Reassure the parents, reassure yourself, reassure the parents, and reassure the kid, and consider the age category and the cooperation expected from this age category. We'll be discussing how the latest guidelines are always rooting for minimal intervention, especially at the emergency visit. You might not want to intervene at all. You just want to clean the blood. Sometimes it's a very tiny laceration that gives a very high amount of blood due to having this laceration in a highly vascular area like the tongue, the back of the lip. So just cleaning the blood and using chlorhexidine gluconate, for example, as a disinfectant, you get much better cooperation after that from the parents and from the kids. So just clean the area, inspect everything, the hard and soft tissues. Make sure the kid is up to their vaccinations, especially the tetanus vaccination. And again, at this age category, it's very normal that they are up to the latest dose. They are probably under 5 years of age, so it's okay. But you have to ask, because some parents do not vaccine their kids, especially with the hype these days. You might want to prescribe some antibiotics. We'll be discussing this later, but just go with the normal clinical investigations, unless there is something that is bigger than your scope of treating. So you might want to refer immediately, like for face fractures, loss of consciousness, head fractures. And you know, when it's beyond a pediatric dentist, you know from how you interact with the incidents. So let's go on with our structured approach. Again, history taken, social, medical history, of course, is very important. The drugs, the last data of the hospitalization, if the child is on some drugs, is having some kind of allergy which runs in their family, and so on. You have to ask these important questions. Cardiac patients, diabetic patients, it affects the management deeply. and ask the trauma history questions, the when the trauma happened, especially if you have a complicated crown fracture or avulsion, especially in permanent dentition. The how, and the how is very important with, again, the consciousness of the kid. Did it comprise a head fracture and so on? And the where. The where is the question of whether to prescribe tetanus vaccination booster or not, and the question of antibiotics. Then proceed with the clinical examination, the extra and intraoral inspection of every hard and soft tissue. And again, be alert to different kinds of injuries that might need a referral to other multidisciplinary team. We mentioned head fractures, facial fractures, also having tooth fragments or lacerations. You might be able to remove a certain fragment from inside the soft tissue, but not every pediatric dentist is capable of doing this. So it's okay always to call the surgeon and ask for their help. And you can also suture small lacerations, but if it's extensive, you might want to ask a surgeon for help. And again, clean the blood. So when it comes to dental photography, this is something that benefited me on a personal level. I'm very loyal to my camera and macro lens. It has personally put me in another track of learning, of documentation, of always patient education, because at a traumatic dental injury, you want to talk to the parents. You want to talk to a kid and show them, if they are old enough for this kind of interaction, show them how it's a very small laceration, how it is going to be treated, show them the teeth before and after, if you have some kind of avulsions and they lost a very aesthetic tooth, and then you could put it back and so on. This kind of interaction brings a lot of cooperation, a lot of trust, and also a lot of education for yourself, especially with the baseline records and the follow-ups. Also, it's very useful in the medical legal aspect, because you have your papers set right, you know what you did, it's following the guidelines, and you know what you'll be doing on the next step. So it's good for yourself before it's good for the patient or the education. And also using a macro lens, it's like a magnifying lens. So you can see details that is not normally very apparent on a personal level with your eyes. You can see some details that are always hidden when you try to look with your bare eyes. And also, if you're an academic like myself, you can take some consents from your patients and use these cases for research issues to learn and educate other people in books, in conferences, in scientific papers, and so on. So I'll always advise of at some time of your dental life in buying a DSLR camera, a macro lens, and a good flash. So let's talk about our structured approach. We start with the clinical tests. You have to know if the tooth is mobile, moving, displaced, which is not necessarily mobile, but not in the previous position or the expected position. Is it tender to manual pressure or percussion? But when we're talking about primary dentition, you do not really have to use a mirror or a metallic handle to perform the percussion test. Using a finger test is usually very enough. And the discoloration, which is having some changes in the guidelines. The guidelines roots for not depending on the discoloration, as especially if it's black or it's getting darker, as a reason for endodontic treatments in primary dentition, but only when you have clinical or radiographic signs of infection. And these are the signs of an abscess, a fistula, having a furcation involvement, for example, if you're having a multi-rooted tooth, a periapical resorption, and so on, but not only using your inspection for a darker tooth and then go for RCT. This is no longer in the guidelines, because most of the time these discolorations are reversible. Sometimes happen due to evasion of RBCs in the pulp chamber, for example, at the time of the trauma, and then after that the tooth returns back to its normal color. And sometimes they persist, the discoloration persists, but they do not necessarily mean there is a necrosis in the tooth or that you need to perform root canal treatment. So do not depend upon this visual inspection to go for the final decision for RCT. And also we're talking about primary teeth, anterior primary teeth most of the time. These are the majority of the teeth that are expected to be traumatized at this age category. And these teeth has very small age span. So sometimes you do not need to go for RCT because they are shedding before ever getting necrosis in their pulp tissues. And also the guidelines have strictly discussed to reduce as much as we can the exposure to radiation, especially again when we're dealing with the primary dentition. So you have always to ask one clear question. If my radiograph is going to change my diagnosis, so go for it. If not, if you're going to still perform the same treatment you decided for at the clinical investigation, do not go for this radiograph. So you only use the radiograph to change your mind, to see something new, something that was not apparent or you cannot see with your bare eye in the clinical investigation. And again, very important to know the ALARA principle, which is as low as reasonably achievable principle to minimize the radiation dose for our kids. Also, when it comes to the cone beam CT, the computed tomography, it's rarely indicated for the primary fractures or luxations. Maybe it's more used in complicated crown fractures or some kinds of luxations like deep root fractures in the permanent dentition. But when it comes to the primary dentition, we're dealing with short teeth, small teeth, malleable bone. You do not get to use a CBCT to change, again, your clinical decision. And of course, when we speak trauma, we have to mention that some of the dental traumatic injuries are due to, sadly, child abuse. So we have to have a systemic approach in our countries, in our practices, on what to do when you suspect abuse. There should be some system, and this is, of course, beyond us as clinicians. We have to cooperate with higher entities, with the authorities. But if you suspect, you have to have the power and the authority to report to a certain entity. And when the incidents, what you see with your eyes, do not match what the parents tell you, the story, when the story does not match, you know there is something wrong. Like, for example, somebody tells you their kid fell over the stairs, and then you have fingers on their face. You can see the fingers drawn on their face. So of course you have to suspect that this kid was hit somewhere, some way. So yeah, you have to have this systemic approach of physical examination and investigating what happened and educating the parents on how to differentiate between discipline and actually causing some kind of abuse to their young ones. This should be arranged in accordance with, like I mentioned, higher entities in our communities, in our countries. There has to be some kind of number that you have in your office that you know you will pick up the phone and call when you suspect something is wrong. I know we sadly meet some cases of these in our offices and our practices. I also have to mention that some types of abuse, not only physical abuse, but also sexual abuse, affects the incisor area and the hard palate in the kids. So again, we have to inspect this. We have to have the clinical and mental training on how to recognize when you have this kind of abuse on our kids, and how to be secretive, but in the same time beneficial enough as a practitioner that deals with the most vulnerable group of humans, kids. This is your job, and you might be the first person to recognize this kind of abuse, be it sexual or physical. So again, we'll be discussing the management from the point of view of the latest guidelines of the American Academy of Pediatric Dentistry. Again, the guidelines have changed towards the minimal intervention. In the old days, we used to extract laterally luxated incisors, and intruded incisors when they are intruded in the position of the permanent successor, and we can differentiate between labial and palatal intrusion using the X-rays. Palatal intrusions are usually, you cannot see the APCs on these, and are usually elongated on the X-ray, versus shorter roots when it comes to labial intrusions. And you can, in labial intrusions, you can see the APCs of the teeth very clearly. So now we do not do this no more. We do not extract. We might extract some cases of lateral luxation. We will be discussing this, but we do not extract intrusions in primary dentition anymore. Why? Because again, you're dealing with a blooded, fearful, hysterical kid and family. You do not want to inflict more pain, use anesthesia, local anesthesia in the emergency visit. And because the damage has already happened, the evidence goes for that no more damage will be happening with leaving these teeth in place, but actually with moving them again during the extraction procedure. So it's better to leave them alone. A very important point when it comes to the management of traumatic dental injuries is the expectations of the parents. You have to lower the expectations and be honest, especially with very aggressive luxations and fractures, especially with intrusions, avulsions, lateral luxations. And this kind of trauma are detrimental to the teeth and the bone, and especially in permanent dentition. Here, again, in the primary dentition, we're dealing with malleable bone that can accept the shock, that can absorb the shock. But most of the time, this kind of trauma in permanent dentition destroys a part of the bone. Probably these teeth are rooted for resorption, ankylosis, total loss in the future. So you have to tell the parents about all the sequelae you expect and about the worst case scenarios, and have them consent for your management, even if failure would be happening, because again, we're dealing with very precious teeth, anterior aesthetic zone. And when it comes to the permanent dentition, you're dealing with teeth that are permanent, are not going to change. And you cannot, most of the time, use implants or bridges for a very long time before the kid can settle with their bone level. So again, be honest, lower the expectations, and make sure they understand the plan and understand that you're doing your best in this case scenarios. So this is what I was telling you. In primary dentition, most of the time you have the malleable bone, the soft bone, smaller teeth. You do not have this severe anchorage you have with the long roots in the permanent dentition. And the crown inclination is most of the time perpendicular to the bone, versus in the permanent dentition, a labial inclination, which absorbs some of the shock, and most of the time crown fractures occur rather than full avulsions or luxations. So that's why we get luxative injuries more in the primary dentition rather than crown fractures or crown root fractures. So let's start with the fractures. What to do, how to know, how to diagnose, and what to do. Before we start managing trauma, for all types of trauma, the parents should be instructed to exercise care during feeding, not to further traumatize or re-traumatize teeth, and to keep the area clean. Use a soft brush, or if they cannot use a brush, we can use cotton swab with chlorhexidine gluconate or with toothpaste twice daily to keep the teeth away from plaque, and to for when it comes to the soft tissue injuries, to make the healing faster and better. This is for all types of mentioned fractures or luxations. Everything we're going to discuss, you have to, for the first time, tell the parents to exercise care during feeding and practice oral hygiene. So we have the enamel fracture. Enamel fracture is a simple fracture that does not involve the dentine most of the time. It's a very little part of the crown that is fractured. We do not need to take a radiograph according to the latest guidelines. You can inspect it clinically with your eye, and if you have a little part of the tooth lost, just smoothen the sharp edge, and you do not even need to follow up clinically or radiographically. It's a very minor trauma, and it probably happens to all kids. Sometimes it goes unnoticed. Okay, then enamel dentine fracture. We have enamel dentine fractures with pulp exposure and without pulp exposure, or uncomplicated and complicated enamel dentine fractures. So when it comes to uncomplicated enamel dentine fracture, the first thing we have to think about is, where is the broken fragment? It might be in 4 places. On the floor, good scenario. Ingested in the digestive system of the kid, not a very bad scenario. Okay, aspired, and this is a very bad scenario. You have to do some kind of chest x-ray, especially when you have respiratory symptoms following the trauma, like coughing. And it might be with the parents, and again, this is a very good scenario. You can easily etch the fragment, etch the tooth, and bond them together. If there is a lost part, you can add composite to it. So the baseline radiograph, logically, you might want to take one, you might want to not, if it's a minor fracture. And of course, if you suspect that the fragment is in a part of the soft tissue, like the lip, the cheeks, or the tongue, you might want to take a soft tissue radiograph to be sure if the fragment is found in soft tissue or not. Again, you can just reattach the fragment, or if we do not have the fragment, we can, after looking for the fragment, we can use a glass ionomer or composite to cover the exposed dentine to avoid further sensitivity with eating and drinking and so on. For the clinical and radiographic follow-up timing, I like to use my logic rather than trying to memorize them blindly. So I want to see this kid. This is a kid that I want to be looking after for like 2 weeks, 4 weeks, 6 weeks, 8 weeks. Okay, and for the radiographic follow-up, I wouldn't think anything would be changed. So I wouldn't think of a radiographic follow-up for this kid, except, and this is a very repeated sentence we'll be saying throughout our follow-ups, if clinical findings suggest pathosis. And this means that you have, again, an abscess, a fistula, mobility, persistent pain in the tooth, and so on. At this point only, you might want to take a radiograph. But other than that, a radiograph is not necessarily taken in enamel dentine fractures without pulp exposures. So you take, you do your clinical follow-up after about 2 months, and you have your baseline clinical investigations, and you do not have to follow up for the radiograph if the kid is well, sound, happy, in no pain. This is with this kind of fracture. A more aggressive form of this kind of fracture, the enamel dentine fracture with pulp exposure. So I want to see a radiograph for this kid to see where the exposure is going. to see the root length, the kind of physiologic resorption this kid has reached, especially if their age is older than 5, 6. This is a tooth that sheds soon, like at 7 years old, if we're talking about a central incisor. So I'd like to see a radiograph for this kid. So for all these age category, I'd like to see a peri-epic radiograph in the paralleling technique, because this is a technique that is well reproducible in the follow-ups. I can use a size 0 sensor, or if you use a larger sensor, we can call it, it's the same technique, everything, but we can call it an occlusal radiograph, because you'll be getting a view of all the upper teeth on this kind of sensor, on this size of sensor, when it comes to this young age category. So whether paralleling technique size 0 or an occlusal radiograph with a larger sensor size. Again, if you suspect the fragment is in the lip, the cheek, the tongue, you might want to take a radiograph for the soft tissue. It might also be ingested, aspired, or with the parents, or on the floor. Since this kind of fracture is a little aggressive, you have to ask specifically about if the child lost their consciousness, because this might let us think about having some kind of head trauma or other types of trauma in the face, away from this part. And also we have to inspect the hearts, the soft tissues, make sure that all the bone is not fractured, and so on. The guidelines again root for minimal intervention, to the extent that we do not have to do anything at the emergency visit, even with pulpal exposure, but only if you know that the kid will come back again in 2 to 3 days maximum. Okay. So you might just want to prescribe some drug, let them go home, clean the blood and all, and then after that, the second time, the parent and the kids are at a better psychology. You can start administering local anesthesia and performing partial or cervical pulpotomy for the traumatized tooth, and restoring with glass ionomer or composite over the pulp dressing material. For the follow-up, a kid undergoing root canal treatment, I want to see this kid in a week, and then 2 months, and then maybe after a year, to make sure everything's gone okay, they are following their shedding schedule, and so on. And for the radiographs, the guidelines suggest 1 radiograph after a full year, because before 1 year you won't be able to see a change on the radiograph. Let's be honest, you need at least 6 months for changes to happen, and in primary dentition we do not expect a lot to happen. So yeah, maybe 1 year is enough with the last clinical follow-up for this kid. Rooting for more aggressive fractures, the crown root fracture. This is the first fracture to include roots in the webinar. It can be with or without pulp exposure. Again, I think this kind of fracture is not very common with the short teeth in the primary dentition and with the malleable bone. It never happens very commonly, but the guidelines suggest, again, you use the same peri-epic radiograph or occlusal radiograph according to the size of the sensor you will be using. Again, the guidelines suggest no treatment in the emergency visit if the child is going to come back. If not, you can start thinking about removing the part, the coronal part that is most of the time loose. And after removing it, you can determine how much is there of this tooth. Is it restorable or not? If it's not restorable, you can extract the accessible part to you, or all the tooth. You do not have to dwell for the EPCs. If a small fragment is still bound in the bone, just leave it for physiologic resorption, and this is the guidelines. If not, you can extract, if it's all accessible to you, you can extract all the tooth. If the tooth is restorable, you can cover the dentine in case the pulp is not exposed. If the pulp is exposed, logically you have to perform some kind of pulp therapy. And we have the same follow-up schedule for the complicated crown fractures. You have to see the kid after 1 week. after 2 months, for example, and after 1 year, and at the end of the follow-up regime, the clinical follow-up regime, you can take a radiograph to make sure everything is gone well with their age category. The last one of the fractures, we'll be discussing the root fractures. And again, root fractures are not very common in primary dentition. And when it happens, it's an apical or middle root fracture due to, again, the short and malleable bone, the short tooth and the malleable bone. Same periapical radiographing or occlusal radiographing, depending on the size of the sensor. If the coronal segment, we have to inspect again the coronal segment. If it's not displaced, do not interfere. Again, minimal intervention. If the coronal fragment is displaced, but it does not interfere with the occlusion, or it interferes with the occlusion, but is not mobile, again, do not interfere. So you leave this fragment even if it interferes with the occlusion, as long as it does not pose a risk on the child, which is the risk of aspiring a part of the tooth. Okay, so you leave it if it is displaced. If it's not displaced, if it is displaced but not mobile, you leave it all the time. You only interfere when there is mobility of this tooth fragment and you're afraid the child will go to home, eat, drink, whatever, sleep, and then aspire this fragment. So at this point, you can either extract, or for the first time, we're mentioning splinting in primary dentition. You splint, reposition this fragment, splint it for 4 weeks, because root fractures, we only splint 2 weeks when we do not suggest bone fractures. Root fractures are one of the aggressive fractures that we might think the bone is affected. It includes a lot of loss of the periodontal ligaments. So it's better give it 4 weeks to reattach this fragment. Most of the time, the guidelines mention a flexible splint. For example, 0.4 wire or less, orthodontic wire, stainless steel wire, nylon, fishnet, and so on. But apparently, these days, the type of splinting is not very important as much as doing it the right way and giving it the right time. So root fractures, you only interfere when the coronal fragment is mobile, and you can interfere either by extraction of the mobile part or splinting it back for 4 weeks. And this depends on the cooperation and the appreciation of the child and the family. If you have an uncooperative child who wouldn't sit through a splint, and if you splint, you know, the splinting is a hard task. You cannot do it in a 2 or 3-year-old kid. So just go for extraction, save the child, and the tooth would change over the time. They'll be having another incisor soon. If not, if they are going to save it, they are going to follow the oral hygiene measures the parents appreciate. Okay, splint it for 4 weeks, and for the clinical follow-up, again, the same schedule, 1 week, 2 months, 1 year. Or if you have a splint, you have to see the kid after 4 weeks for removal of the splint and follow the rest of the schedule, 1 week, 6 to 8 weeks, and 1 year. And since root fractures are one of the most aggressive fractures, you have to see, according to the guidelines, the kid every year until the eruption of the permanent tooth to make sure nothing is wrong with the sequence, the position of eruption. If you extract, you only have to see the child after 1 year, for example, and this is enough. You do not have to go through the long follow-up schedule clinically. And for the radiographic follow-up, you only need to see this kid if clinical findings are suggestive for pathosis, like, for example, RCT needed for an abscess or a fistula or so on, or mobility or so on. For alveolar fractures, I personally think alveolar fractures are beyond the capabilities of a single pediatric dentist. You can diagnose alveolar fractures by having a segment of teeth in mobility, not one tooth, not 2 teeth, maybe a segment. Most of the time, because this segment is out from its place, like in this photo, you will be having occlusal interference. Again, you do the same periapical radiograph with size 0 sensor or occlusal radiograph with size 2 sensor. And for the first time, further imaging techniques are introduced because this kind of fracture might not be very apparent on just a periapical radiograph. So you might want to take a lateral radiograph. You might want to refer, and a surgeon might ask for further techniques like a CBCT or so on. What we do with alveolar fractures, we reposition and stabilize again for 4 weeks. And this is the second time we mention splinting or stabilizing teeth in flexible splints for the primary dentition. The first one we mentioned in the root fracture. The same schedule of follow-up clinically. You want to see this kid after 1 week. You have a splint, so you have to see the kid after 4 weeks to remove the splint. Then 2 months, 1 year, and each year until 6 years of age when, if we're talking a permanent incisor, when the permanent incisor erupts. And for the radiograph, again, the guidelines is different in this part. You have to see the kid with another radiograph at 4 weeks because you have to make sure the bone is healing, and you have to see them at a 1 year schedule to assess the position of the healing and whether the fracture line covers the roots of the primary teeth, whether the permanent tooth germ is affected, because most of the time if the fracture line occurs on the tooth germs or the apices of the primary teeth, abscesses can develop very easily. So we mentioned enamel fractures, enamel dentine fractures, enamel dentine pulp fractures, crown root fractures, alveolar fractures, and root fractures. Now we come to the luxations, which are the more common encounter in the primary dentition. And luxations are also called soft tissue fractures because at this kind of trauma, the periodontal ligament is affected for the first time. In the fractures, we do not get an affection of the periodontal ligament except in root fractures and some of the crown root fractures. In luxations, most of the time, the periodontal ligaments are affected. Concussion is one of the easiest trauma and happens again all the time. It must happen to you or to me at some age, at some point of our age category. The tooth actually is not mobile, is not displaced. There is no periodontal ligament cut. The sulcus is not bleeding. The clavicular sulcus is not bleeding, but just a blow to the tooth might cause a little tenderness. It might happen sometimes when you eat something very hard and you have this ouch feeling. So it's a very mild kind of luxation. You do not need a radiograph. You do not need a treatment. And you do not need a follow-up most of the time, but you can see the kid after 1 week and then 2 months, and you do not need to follow up after that. You do not need to use a radiograph unless, again, there is a suggestion of pathosis from a clinical point of view. So this is one mild luxation with just some tenderness to the tooth on biting. Subluxation is the stage before actual luxation. It's below a luxative injury. There is mobility in situ. The tooth moves in place, but it's not very mobile. It's not displaced at all. And you might see some cellular bleeding around the crevice of the tooth due to cutting some of the periodontal ligament at this point. You can take a radiograph with the same technique we mentioned earlier, size 0 sensor with the paralleling technique, or an occlusal radiograph with a bigger sensor. You do not need a treatment, just follow up the oral hygiene measures, brushing the teeth, exercising care during biting, and you can see the kid after 1 week, after 2 months. And if there is a suggestion of some clinical problems, you can still see the kid each year until the permanent successor arrives. The radiographic follow-up, again, is not necessary unless there is clinical symptoms suggestive of pathosis. Okay, now we talk extrusion, lateral luxation, intrusion, and avulsions. These are very common in primary dentition, and we have to know how to manage because you are going to see them in your practice at least once every 2 or 3 months. Extrusion and avulsion are the same. Extrusion is half an avulsion, semi-avulsion. The tooth is not fully out of the socket, okay? It's not fully avulsed, but it's excessively mobile. And again, we have a problem with mobile teeth or mobile fragments in this age category when we have not developed the sensation of coughing good enough. So you have to be aware with the aspiration of this fragment or of this tooth. Clinically, the tooth, of course, will appear longer than the contralateral tooth. And on the X-ray, you can see the periodontal ligament thicker in space. You need a radiograph for this because you have to make sure that all the tooth is extruded, not just the coronal portion, for example. It might be a crown root fracture, a crown fracture. You have to make sure how to manage through a radiograph. Guidelines, again, for the minimal intervention, if the tooth is not interfering with occlusion and not excessively mobile, you can again leave it for spontaneous repositioning. If the tooth is excessively mobile, this is a hazard. You have to extract. We do not splint extruded teeth in the primary dentition. Why? Because we have a permanent successor. We do not want to put the tooth back in some positions that might inflict a damage to the permanent successor. So again, we do not splint extruded teeth in primary dentition. The follow-up schedule is the same as the previous luxation, subluxation, but we might want to see the child again every year until the eruption of the permanent successor. Extrusion is considered a mild, the milder of 4 mentioned luxations, the milder amongst lateral luxation, intrusion, and avulsion, because the direction of the force is away from the successor. So most of the time, the successor is not damaged. But when we talk about lateral luxation or intrusion, most of the time you get hypomineralization of the permanent incisor in the future, brown spots, and so on. And avulsion, again, it's away from the direction of force is away from the permanent successor, but the initial force is so strong that the tooth is lost totally from the socket. So again, the successor must go through some kind of damage. But extrusion, it's a mild one. So again, we do not suggest radiographic follow-up unless there are signs of pathosis. For the lateral luxation, the problem with lateral luxation is a change in the movement in the direction of the tooth root. So it is away from the bone and the successor on one of the sides, but into them on the other side. And most of the time, bone is damaged by lateral luxation. So the tooth is not mobile, but the tooth is displaced in a different direction than the long axis of the tooth. It might be in a buccal palatal direction. In very little scenarios, it might be mesial or distal displacement. We have to see a radiographic X-ray to make sure where the position of the tooth is, and if it's laterally luxated or intruded, to make sure you can take a clinical decision. Again, guidelines root for the minimal intervention. If the tooth is not or is causing occlusal interference in a minimal amount, leave it for spontaneous re-eruption. And most of the time, these teeth re-erupt into their previous position after a maximum of 1 year. If we have a severe displacement to the extent that the kid cannot close their teeth, cannot occlude properly, you have 2 options. You can reposition and splint, and this is the 3rd time we mention splinting in primary dentition after root fractures and alveolar fractures. And we splint for 4 weeks, not 2 weeks, because we consider this luxative injury causing some kind of bone affection. Or, again, if you do not have a cooperative child or an appreciating family, you can just go for extraction. The follow-up schedule, in case you have a splint, you go through the 1 week, the 2 months, the 6 months, the 1 year, but put the schedule for 4 weeks for desplinting in between. And if you did not splint, if you extracted, just follow for 1 week, 2 months, 6 months, 1 year, and each year, because this is a very aggressive kind of luxation, you have to make sure the permanent successor is not affected and is in place and sequenced at the right time. Radiographic follow-up is dependent upon the appearance of pathologic signs clinically only. So for lateral luxation, we extract or splint for 4 weeks according to the kind of occlusal interference and the cooperation of the child. Intrusion, again, the tooth impinges on the permanent successor, again, a very risky kind of trauma in this age category. We have to see a radiograph, and we do not intervene in intrusions in primary dentition at all. These are the latest guidelines. Just leave the tooth where it is. It will opt for a spontaneous re-eruption. And if not, we do not want to inflict more trauma on the successor. We leave it until the time of shedding. And most of the time, I've seen cases of intrusion, a lot of intrusion cases. Most of the primary trauma cases I've seen were intrusions, and they always re-erupt. The same clinical follow-up schedule, 1 week, 2 months, 6 months, 1 year, and then each year until 6 years of age is the time of eruption, and only radiographic follow-up upon clinical signs of pathosis. Avulsion, complete tooth lost from the socket. For avulsion, we deal with this luxative injury as we deal with the fragment of a crown or a crown root fracture. We have to inspect the position of the tooth. But before inspecting, the first question we have to ask when you have a parent calling you and telling you they have their kid have knocked their tooth out, you have to ask them, how old is your kid? If the kid is below 6 years of age, discard this tooth. You do not have to search for it, but make sure you see it. Make sure it's not in the nose, in the chest, in the digestive system, in the soft tissue. If the kid is older than 6 or 7 years old, this is a permanent tooth. So you have to assure they are coming very soon with the tooth in milk or in Hank's balanced solution. We will be discussing this next time, to replant it as fast as possible with the least extraoral dry time. So again, first question for avulsion, how old is the kid? If it's a primary tooth, discard it. We do not replant primary teeth as we called with extrusion. We do not want to inflict more trauma on the permanent successor. And of course, the radiograph is very important in avulsion to differentiate avulsion from intrusion, from crown on mass fractures, from crown root fractures, and also to make sure the bone around the tooth was not affected by the blow or the fall. Avulsion, you do not have the tooth in socket, so you just want to see the kid after 2 months and at the time of the eruption of the expected central permanent incisor. And again, for the radiographic follow-up, it's only upon suggested clinical pathosis. So, splinting, conclusions. Splinting for alveolar bone fractures, 4 weeks. Root fractures, if you cannot, if you guarantee the cooperation from the side of the patient and the family. And again, in lateral luxations, but you can always extract in both root fractures and lateral luxations. 4 weeks for all, because all of these fractures include damage to the bone. And when the bone is damaged, you need at least a month for full healing. Again, if the kid suffers some laceration in the soft tissue or a lot of blood, you have to ask about the tetanus vaccination. And if the patient is in a kind of very aggressive fracture or luxation, as in with intrusions, when the bone is affected, lateral luxations, root fractures, you have to prescribe some kind of painkiller like acetaminophen, ibuprofen, according to their, again, medical conditions. Some children are contraindicated for ibuprofen or acetaminophen. You have to make sure they are not. You have to make sure they use it for other, for example, fever, for other, they are used to using it at home. is safe for them, because the pain sometimes is unbearable for this young kids, and you have to perform your treatment, lower the expectations when you do not expect a full success. Talk with the parents, document every fault you can, every treatment plan. Talk with the parents and make sure everybody accepts the treatment. Assure the parents, assure yourself, assure the kid. And if the child is compromised in their immunity, like for example, a diabetic uncontrolled child, or having any other problem, or if the laceration is too big, too much, too many lacerations, the guidelines leaves the antibiotic prescription at your discretion as an operator, as a clinician. You can prescribe antibiotics with severe soft tissue problems, or with a compromised cleanliness or immunity. Of course, you have to be aware about the medical status of the kid before every intervention. You have to take a medical, social, and a trauma history, as we started with. The reference for all of these is the latest guidelines, again, of the American Academy of Pediatric Dentistry. And these are my contacts: email, Facebook, and Instagram, and WhatsApp. I'll be happy to be contacted by any from your side of the EDPA audience. And again, I'm very thankful for having me today. I'll be listening to your questions, and thank you.
Okay. Thank you so much, Dr. Dina. It is now time to answer any questions you might have about our topic today. We will start with the questions already posted. You may submit any questions you may have in the chat box. I will be reading them one by one for Dr. Dina to answer. So our first question is by Berhan Yilma. How many millimeters of intrusion have you seen spontaneously erupted?
Okay, so the question of how many millimeters is not asked in the primary dentition nowadays. We used to ask this question in the past, but the guidelines route for this question when it comes to the permanent dentition, we discuss 3 millimeters. Below 3 is acceptable, 3 to 7, and 7 you have to surgically intervene. But with the primary dentition, most of the time, like 90% of the cases, spontaneous eruption occurs, also because you're having a very short tooth with a very short crown compared to the permanent dentition. So you might not want to intervene at all when it comes to intrusion, even with a severely intruded tooth, if that's your question. But if the guidelines mention if the tooth is causing pain, is severely intruded, is causing a lot of trauma, a lot of pain, you can extract the tooth. But this is a very tight scenario to be using. Most of the times I've seen teeth fully intruded, but they re-erupt clinically. I've seen them clinically.
Okay, thank you, doctor. The second question is by Dr. Mabratu Hailu. Does age matter for splinting?
Does age matter for splinting? We are talking primary. Of course, it does for the operation, but we're talking primary versus permanent dentition. But of course, when you talk about a 2-year-old kid and you're trying to splint teeth for this kid, how would you put the kid to sit? We can use the knee-to-knee position in most of the very young aging in children, 2 or 3 years. But splinting is a hard issue, because you have to use an etchant, you have to fully dry the tooth, you have to use a bond, you have to use composite, which is technique sensitive. So yeah, the age and the cooperation more than the age, it matters. But we mention in the guidelines, we mention splinting nowadays only if the cooperation of the kid and the family allows it. So consider the other factors before you opt for the final decision. And at the end of the day, all of these teeth are going to shed again. So this gives some kind of relief. You'll be having another teeth.